Hello and welcome to the Open College podcast series. My name is Oxana and I'm the host of this podcast. On this episode of the podcast, we have my colleague Daryl Mahon. Daryl is one of our lecturers on the BA in Health and Social Care degree programme, which we have in partnership with Oxford Brookes University in the UK. Daryl has many letters after his name, and some of his qualifications include youth studies, counselling and psychotherapy, leadership and management, and at the moment he's completing a PhD in social science. He is definitely an expert on the topic of addiction after having worked extensively in areas of rehabilitation and drug misuse. Here's what Daryl had to say when I asked him what addiction is.
Okay, yes, so I guess if we're looking at addiction and what it is, I suppose it's first important to define it, and when we go to start really unpacking that and defining what it is, we encounter lots of problems. And as with any field of, I suppose, academic study, you come across different ideologies, paradigms, different approaches, and they all, they have different opinions. They do often converge, but generally there's different opinions. So I suppose first of all, it'd probably be looked at within the medical model. So if you look at some of the books on mental health, the disorders, quote unquote, there, it's not a term that I'm too happy using myself, but in the medical model that's what's used, and they define addiction, and they would really only define it more so in this sense of substance addiction. And how they go about defining that, so a couple of different characteristics to be diagnosed as with substance use disorder, and it's a real American term, is that you would have to have loss of control over the substance. So you feel like you can't stop using. It has to be characterized by tolerance, i.e. the longer you're using, the more you need to use to get the same effect. And then there has to be some other different behavioural consequences in the person's life around work, maybe not able to hold on to employment, hospitalizations, being sent to prisons, etc. So that's the real medical model of it. However, we can unpack it further and then look at behavioural addictions, where there may be something along the line of food, issues with food, intake of food, sexual addictions, alcohol, etc. So there's quite a few, but really what we're looking at on a general, I suppose, definition is that it is a behaviour or a substance that is causing difficulty to a person. There's a sense of loss of control, and there is often a number of consequences that go along with that, be that legal or societal. So it's really a complex area.
There's lots to say about it. We'll just keep it to the kind of basics, I suppose. So when it comes to the types of addictions out there, obviously, how do you know that we'll stick to the substance abuse, I suppose. How can you tell that somebody has an addiction?
Okay, wow, great question. I think we may, I suppose, society, when I say we may, generally make assumptions about people who use substances and are indeed addicted or not. And they may often have that stereotypical vision of someone who's down and out, who may be homeless, they're on the street, and you can really see the impact the drugs have had physically and mentally on them. So that's really probably one extreme. Down the other end of that spectrum, and it does occur on a spectrum from recreational to what being actually addicted, which we can probably go back to in a minute if you're interested in that. But the other end of that is then someone who's using drugs who is psychologically or physically dependent. There are other characteristics of I suppose, a diagnosis of addiction, but they may, I suppose, their life would be such that you probably wouldn't recognize it for the type of substance that they're using may not have that effect that maybe something like heroin or crack cocaine would have. But also then they're able to hold down their job. Their relationships may not be impacted hugely. They're not out committing crime, so they're not within the justice system or homeless system, etc. So they're not at that stage, and not that he won't get there, but they're not at that stage at that moment in time where I suppose the life would seem to be out of control in some way, and their quality of life has really diminished. So there is people out there who take drugs. You wouldn't actually notice it. They may be in your office, they may be in our building. You may actually live with people like this and not actually pick up on it, because I suppose part of addiction is also being secretive and keeping it hidden as well as you can from people. So it depends on the drug of choice that the person is using as well. Cannabis may not present as much social or personal issues as someone who was using heroin and has a chronic heroin or crack cocaine addiction.
So that's how you can kind of identify various. It depends on the kind of drug that they're taking, I suppose.
Well, yes, that would be on if I could just come back in there. That would be on an observational level. So if you're working clinically with somebody, so if I was working maybe as a counsellor or a therapist with somebody, there'd be different assessment measures that I could also use as well. Someone on top of the mind would be the addiction severity index. And as I spoke to you a while ago, it's not all or nothing with addiction. It often occurs on the spectrum from recreational, which most people never develop a problem with drug use. They may use weed or cannabis on the weekend, and that's fine. They use that recreationally. Or they may use other stimulants or other drugs on the weekend, and it doesn't become a problem for probably 90% of people. It's a smaller amount of people that may have other underlying issues that it can actually get to that stage with. So we were looking at really doing an assessment with the person to see where they would be sitting on that spectrum, and then that ultimately then really provide a clearer picture of the type of support that the person needs to actually address those issues should they want to.
Okay. And then when you were just saying there about the underlying issues, would that be mainly like mental health problems, or could it be, I don't know, some kind of, I suppose a trauma is a mental health thing, but
yes,
do you know like what kind of things
absolutely
would make someone addicted?
I think the answer to that is there's no clear answer, or no standardized answer, at least, Oxana. So I guess there's a lot more research coming out on trauma over the last probably 5 years specifically, but it's been ongoing in the background for quite a long time. And you're absolutely right when you say that trauma will be a mental health issue. So yes, I guess if you go out into the population and if you were to say do some type of research project, and you're looking at people who have chronic addictions, and you sit down and speak with them, you'd be hard pressed to find somebody who hasn't experienced some type of trauma across their life or across their childhood. But in many cases, you're going to be meeting people who have multiple traumas, ranging from everything from parent separation when they were younger to, I suppose, issues around parental capacity, how people may have been raised. You're meeting people who have often, and I don't want to generalize too much, but often have traumas that are really, really, really difficult to get over, and they play out then. Often stuff that happens in childhood and younger years plays out as people get towards adults, and in later life it really starts to manifest. So that's one aspect, and I suppose a lot of the time, instead of diagnosing people using these manuals such as DSM, etc., for anxiety and depression, or personality disorders and the rest of the clusters that you would find in those manuals, a lot of the time trauma is really what's going on underneath all that type of stuff. And that's just really one area that can influence people developing problematic relationships with substances. The other one, and is a huge one, is really social deprivation, so marginalization, exclusion, poverty. These are all real the structural factors that we talk about in sociology, the structural factors that then impact policy, stuff like intergenerational poverty, clustering people together in communities of deprivation and disadvantage, access to services, access to life opportunities, access to basic determinants of health. So there's a huge stuff going on, and in a lot of cases the people who end up with really chronic problems, and people who you may see out or you meet being homeless, a lot of the time there's a complex mix of traumas and societal issues, structural issues that are really kind of meeting there and converging. So it's never really only one issue for some
case
people.
by case. Yeah.
Exactly. Yeah. It's not great that, although we can generalize in conversations, I think when you're meeting people on a one-to-one basis, you really need to just get to know them and get to know their background, because it may not always be a case that someone suffered a horrendous trauma, or, you know, there's people who come from all walks of life who develop addictions. They come from, you know, middle class, they can come from well-paid jobs where, you know, stress may have got the better of people, and they just learn to, you know, lean on a couple of drinks or some cocaine, and things just escalate. So it's biting. And I think the one thing to impress upon people and to the listeners is that drug users aren't homogenous. You know, they're not all the same. There is different backgrounds and different reasons why people do use drugs.
Yeah. And how would you then, I suppose, what help is out there for people who come out and they say, look, whatever kind of problem they have at whatever level, what is there out there that can help them from, I suppose, from family all the way through to the system?
Okay. So so we'd have a bit of, let me try to mind map this. All right. So I guess we look at really the approaches to maybe prevention and treatment first of all, and to understand the responses that Ireland specifically takes, and the policy positions that Ireland takes in regards to this issue. I'd have to go back to the national drug strategy. So it's the only really game in town, as it were, when it comes to the policy and the funding and provision of services in Ireland. And so we've relatively recently, I think it was 2008, had our last strategy, and it's a 7-year strategy. So it'll be live until, I think, maybe 2025, in around that. And what that is, there's been a number of them over the years, but where we're at now is the latest strategy is called Reducing Harm, Supporting Recovery. So it's a two-pronged approach, if you will, where previous strategies have probably more focused on the abstinence side of, you know, getting people into treatment, getting them drug-free, getting them abstinent, and then trying to help rebuild their lives. There wasn't always a huge focus on what we call the harm reductionist approach, although there were services doing that. The policy positions probably didn't support that as much as they are within this strategy. So the strategy is a coming together of all stakeholders in society, so public, civil, community, voluntary organisations, and they have thankfully just really kind of started taking service users' opinions and experiences on board into that to design and be part of service design. Some may say it's tokenism, but at least we've started. So and to come back and answer your question, at the most probably basic level, so the first probably way a service may interact with someone is through what is called harm reduction, and that often comes in tangent with what's called low threshold services. So that's a whole ideal and a philosophy or ideology about meeting people really where they're at and keeping the bar really, really low so that people can enter and get support of your services, because there's a lot of services out there that won't actually work with people until they are abstinent, which, you know, it's sometimes it's a bit difficult to get your head around, but I suppose you can also see why they're doing that. They have a specific remit and they want to focus on that area. But I suppose in some ways it's akin to asking a depressed person to stop being depressed before you sit down and work with them.
Yeah. So
there's the abstinent and the harm reduction. So harm reduction is both a pragmatic approach, but it's also a policy or a philosophy about I suppose advocating for policy positions. So it's situated in a real human rights and social justice paradigm. It's about meeting people where they're at, keeping them safe, and your agenda may not necessarily be about having someone become drug free, and in actuality it's often not. It's about how can I help this person at this point in time stay safe and often stay alive, to be honest. So there's pragmatic strategies such as needle exchange, so providing a needle and syringe program for people who use drugs intravenously, so giving clean needles. So obviously, you know, hepatitis C, HIV, etc. It's not spread between people who use drugs, but I suppose at the policy position, you know, they're probably concerned that spread over then into the wider society. So it's about harm reduction, about keeping the person safe, but also then keeping the society safe in some way. So your strategy may be, I suppose, a good way to describe it, and people often look at me funny when I say this, is that you are not you are educating people how to use drugs, not educating them how to not use drugs. So it can be about how to inject safely into the correct veins, how to look after your body, how to look after abscesses. Maybe not mixing certain drugs because it can be dangerous. So it's a really practical and pragmatic approach to giving people information to keep them alive, basically, and improve their quality of life in some way. And great if that person then wants to become abstinent or go into a rehabilitation or treatment center, absolutely fabulous. But I suppose the end goal in itself is actually keeping people safe and alive while they're using illicit drugs.
And would that not be seen as maybe, look, I'm not an expert on this, but would that not be seen as like enabling them then?
Very
because
good.
If you're
Finish. Do you want to finish what you're saying there?
No, I was going to say it might be seen as enabling them, because even though you're showing them how to, I suppose, take something that's illegal safely, like you could die from an overdose. So that's not safe either. Do you know what I mean?
Absolutely. So, and this is, and I'm really glad that you brought this up, and it's something that a lot of people would say, Oxana, and I guess from a position of standing back, that's in, from the average everyday person, that's probably something that you would hear a lot of. But I guess there's so much to this, and I do want to do it justice, because I'm aware that there's probably people listening to the podcast that would probably have a similar opinion. So I think, first of all, harm reduction is really situated in a human rights based approach. And if you look maybe to some other countries where they don't give needles out, and the rates of HIV, the rates of people dying, and indeed the rates of people overdosing because they're not engaged with services, so they're really, really hard to reach people anyway, and they literally have zero support, so they are going to overdose. In fact, they're more likely to overdose without some type of connection to a service in the first place. I think that probably brings us into really discussing the legislation about the medical supervised injection centres that have been passed in Ireland a number of years ago. I was actually Anna Liffey done most of the work on that. I was actually working with them at the time as a team leader, and that legislation went through the Oireachtas and got passed. So basically what that is now is that there's provision to have a safe injecting space in Dublin city centre. Now, obviously, that provides a number of benefits to people who are using. They're not going to be sitting in a corner lane with excrement and with dirt around them, sticking dirty needles into their arms, and the health consequences that come with that. If they do overdose, there is a doctor and a nurse on site who can provide oxygen and medical procedures if a person does get into any trouble, where it's not going to happen down a lane or sitting in some corner block of flats somewhere. There's then the added benefit of not having needle and syringes lying around out in the streets, which is a huge problem in town, in the north inner and south inner city. So it's taking needles off the streets, and it's taking drug use off the street in general. In addition to that, then you would have workers there to meet the person and meet their basic care needs, be that homelessness, addiction. There's so much issues that go along with it, be that mental health, comorbidities, physical issues, abscesses. I've worked with people who've lost their legs, ended up in wheelchairs from abscesses, from not having that medical care because those type of services weren't available, or they weren't being utilised at the time. So I think enablement, for me, it's probably not the right word to use. For me, I'd call it support. I think enablement is often situated within an abstinence-based approach from people who think that any type of interaction with someone who's using drugs, that's not based on trying to reduce or stop them using that drug is considered enablement, and that wouldn't be the position for myself. I think a lot of the trouble that we actually have, and we bring it back to harm reduction and the policy and advocating and the human rights and the social justice aspect of it, a lot of the actual issues with drug use is actually because they're illegal. And if drugs wasn't legal, a lot of the problems that go along with it, people going to prison, they're getting criminal convictions and all the rest of this stuff, is actually the problem itself, and how society and how we view drug use. And we are often influenced by the media and by different, I suppose, bodies in actually how we were conditioned in a lot of ways and how we do that. We only hear the horror stories. So for that small majority of people, very, very small majority, that drug use does become problematic, we need to really be working with them to support them. So the same people who have suffered huge traumas, who continue to suffer huge marginalisation within communities because of social policies and structural issues in this country, are then the people who are being criminalised for, buying €20 worth of drugs to support a habit that they're trying to escape the pain and trauma, who are then sent to prison. Taking up huge resources from the country, 100,000 a year to hold a person in prison for 12 months. That's without the solicitor's fees, court case fees, and all the rest. So for me, there is really only one way to be working with people who do have problematic. Not only one way. I would always encourage the harm reduction way. I work within different ways as well. But ultimately, you're not going to be able to do a counselling session with someone who's using drugs really, really chaotically and just coming into your service to get a clean needle. That's not the time for those guys. But when they are ready, those services are there as well.
Yeah, so you're kind of saying, I suppose, instead of criminalizing these people and putting them straight into prison, do some kind of intervention first.
Absolutely.
Then,
so and I think that's what we're moving towards. So for decades now, drug use has existed within the criminal justice system. So anything to do with drugs, if you're caught selling drugs, I suppose selling drugs is a bit different, and I don't want to get into that, but if you're caught using drugs, you're sent to, you're more likely are not charged and sent to court, and depending on your circumstances, sent to prison. What we've started to do now is, with this drug strategy as well, and the passing of the legislation for the medically supervised injection centre, is to start bringing them more into a health-led sphere. So that means we're looking at people as actually having a illness of sorts, a medical condition where they need medical interventions and they need psychological interventions, and indeed psychosocial interventions. Social care workers would have a huge input into that, with care plans, advocating for people, helping them meet their basic needs, etc., as well as counsellors then maybe working with some of the trauma type stuff and relapse prevention. But absolutely, so we're moving as much as we can from the criminal justice system, although it's still used far too much, in my opinion, to a more health-led approach. And I guess with that, when they were doing the consultation process for the last drug strategy, I actually met the then Minister for Drugs, Catherine Byrne, a minister with responsibility for the national drug strategy, and I showed her around Anna Liffey in the different services, and we had a nurse's surgery, etc., in there at that time. And we were talking about the decriminalisation of drug use and drugs, but I guess it actually didn't get enacted anyway down the road. But what she was talking about at the time is turning we currently have a drugs court, so people who are caught with drugs generally for their own in their possession for their own use can go there as an alternative to prison, where they will go to court and they will do a type of structured day program where they may engage in education, etc. So we do only have one of those in the country, I believe, possibly two, but they only cater for a small amount of people. So it's one part of the intervention approach.
And can I just loop back then, because you were talking about the supports with providing the clean needles and a safe space to, I suppose, to use. Do you find that the people that come to these I don't know what they're called, I suppose these facilities to avail of the clean needles and etc., would they be the type of would they be the people that actually want to get clean and they see this as a first step to get to abstinence, as you say?
Yes and no, but probably not. But also, okay, we'd have a lot of places. It depends where. Sometimes it's actually needle and syringe provision can be actually done out in the street, where they'd ring a number and a worker would go meet them, quietly down the lane and just provide them with that. But generally, a lot of services do that within the service. A person is really a lot of the times just coming to get the needles, so they get needles, condoms, and different paraphernalia, tinfoil if you're smoking heroin, or indeed crack cocaine pipes. There was actually a story in the newspaper the other day that 50,000 have been given out I'm not sure if that was this year or since they started doing it. I imagine it was probably just this year because we've been giving them out for quite a while. So I suppose a lot of the services that do that and give those out would be, as we spoke previously, is about harm reduction and low threshold. And the whole idea of low threshold philosophy is keeping an open door. And when you're working that way, you're not just working with the drug use and the harm reduction aspect, but you're also very, very often dealing with other really problematic behaviours, violence, people kicking off, getting angry, shouting, threatening workers. So it's a really, really chaotic environment. It's not like a treatment program or centre you'd see on the TV.
Yeah.
You're generally working people out homeless, sleeping on the streets, in hostels, but the guys' lives are really, really difficult. And a lot of people, they don't have anything. A lot of people have no family. They spend their days walking around the streets on their own. I don't know if you've seen that documentary there the other night on RTE about the guys homeless, which really, really quite sad. And people, angry, and understandably, people are angry that their lives have turned out that way, and there's nowhere for them to go, nowhere for them to sleep. A lot of services won't go near them because some of the problematic behaviours that they present with. So there's a very, very, very small amount of services within the whole country that will actually work with people at that level. Generally. At the centre, around the city centre in town and stuff. There's lots of other community programs that would work with people at other levels. But when you're getting to that stage where people are homeless, huge mental health difficulties, just a whole host of issues. Getting drug free is probably the last thing on their mind until they have a stable bed under their back.
Yeah, that's actually. I'm glad you actually brought that up, because I was going to say, would you think there's enough of these services around nationally, or just full stop? Is there enough that's done, or what else do you think should be done? And
okay, I think if we get looking at that, okay, so let's take the talk, just keep on the harm reduction and the type of work at the moment. So if you look at that, a lot of the people that those guys you work with will be coming out of hostels, or around, who'll be hanging around the streets and maybe using drugs and whatnot. So there'll be only really 2 or 3 projects that do that in town, north inner city and south inner city, which would be Analiffey and Merchants Quay. And in Merchants Quay have a whole place where they give food. Analiffey do the same, but on a smaller level. So they have nurses, they have doctors that people come in. They actually even have dentists, so specific for these services that people can go in and see. So that's great on a human rights level to look after people's basic needs. I think then each probably community around specifically the communities that are in the national drugs, the local drugs task force remit, and that's another level. So you have a strategic level. Generally, communities that have been identified as experience deprivation and social disadvantage. So if you look at like Ballymun, where I grew up myself, north inner city, south inner city, Tallaght, Clondalkin. So all those areas that you'd probably hear stories of drug use and criminality about, etc., would have a task force, and that's a body that actually responds to the local issues. They fund different services through the HSE, and in generally all those communities, you probably come across at least definitely 1, but often probably 2 drug projects, in addition to other types of family support services, etc. And those guys would be under resourced as well. But then if we actually scale up and look at rehab treatment, so going in somewhere to get a detox, and B, a bed in a treatment centre for a number of months, where you can actually start working on those issues that have caused and exacerbated the drug use. So you can go in and so therapy, basically more therapeutic approaches. There's probably about 20 beds in the whole country. I could be probably 30, and I could be wrong on that, but there wouldn't be much more than that. And beds for actual detoxification. So if someone needs to go in, and if you're using heroin, generally you'd be taking something called methadone or Suboxone, which is an opiate replacement treatment. And you do that for a number of weeks within a hospital setting. So there's 2 wards, one in Cherry Orchard Hospital, which has about 6 or 8 beds, and one in Beaumont St Michael's ward. That's the extent of public beds for detox. But then a couple of the treatment centres like Kilmoyne and a couple of other places may have another 6 or 8 beds themselves. So there's really, really a scarcity of beds for that, and people can be waiting up to a year to get into these places. And if you're using drugs or trying to cut down drugs, and it can be just so hard, because then you have to give clean urines onto that, And it's like, we're asking people who are addicted to, to get stable first before they can come in. So it's a real, rock and a hard place for many people. Unless you're really, really there, you have that 100% motivation, but that's not the reality for most people. Like any of us trying to change a behavior, whether that's get up earlier in the morning or start jogging, etc. The motivation can lack and can be a little bit transient at times. And then we'd have the rehabilitation centers like Kilmoyne, like Keltoy, Peter McFerry's has a place. Again, you're looking at a couple of dozen beds across the whole country. So we absolutely need to be putting more into treatment and rehabilitation, inpatient beds. Absolutely, we need to do that, and we could do it. I suppose buffing up the community sector a little bit more. Ultimately, if we look at it, it's going to save money in the long run. So just like, not criminalising people for actually having drugs in their possession, opening up more opportunities for people to actually go in and get drug free and go on and build a life has, there's immense benefits for the individual, their quality of life, their communities, their families, their education, what they contribute to society, taxpayers, etc., all the rest of that stuff. But then there's also then the for every person that does go in and change their life in that way, the wider society for resource allocation is going to feel that as well. Less times in courts, less time in prison, less time maybe in hospitals for overdose and all that type of stuff. That the person is not only contributing to society, but then they're also then not maybe for some people at least not using up as much resources in a scarce kind of public sector.
That's crazy. I never knew, like, this isn't my area. Social care is not my area at all. I never knew how limited it was, because you hear about like, oh, there's these services and there's these services, but that's kind of like all I would hear. I'm not in it, so I don't know, So from the offset or onset, whatever you call it, it sounds like a lot, but really when you start digging into it, there really isn't much there. That's mental. And what about people then? So say, for example, you're addicted to something, then you go off and you look for help in a service and they turn you away. Is it possible for someone to actually go cold turkey, and how long does that last if it does work out?
Okay.
Can they just get clean because they're just so, willful?
The answer to that is yes. I'll unpack that a little bit more. Okay, so it's I don't think anybody would just be turned away from a service without something put in place. So be that, we'll refer you here, you can go there, but you can't, it may be the case that, you can't come in here because you're still active using drugs, and, you have to give some urine, which, urines as well is something that I dislike. It's very, it can be humiliating for the person asking them to urinate into a bottle in front of you. With someone it's not like a doctor's office where you get the bottle and go into the toilet on your own. It's there's someone standing there watching you over your shoulder to make sure you're not avoiding
to make sure it's there. Yeah,
make sure it's there. So I know that's another kind of human rights issue for me. But anyway, so generally there wouldn't be person be turned away, but people absolutely, because of the waiting lists and because of the trouble getting into services, and I suppose the bar is often raised quite high. Now, generally what a person in those circumstances may do was start linking in with a community organisation in one of their communities where they'd have counsellors and key workers and social care workers, and start doing care plans and looking at how can I reduce my drug intake or substance intake or whatever the behaviour may be, and start working towards getting into a treatment centre. So that generally that's a lot is done there, but equally people just they decide one day, I want to stop using drugs, and they do go off and do cold turkey. And this is an interesting one because we wouldn't have, there's not a lot of stats on that, but what I would say, and this is really interesting, and it probably speaks to some of the stuff I was talking about earlier, insofar as the impact that like social deprivation and lack of social capital and resources has. There is research out there that about 50% of people resolve serious addictions without ever going to any service at all, without linking in, without going to counselling, without doing anything. And I guess what the research is saying in those circumstances, that this type of person, the people who do that and go on and do well, are people who already have what we call recovery capital. So recovery capital would be kind of drawing on Bordeaux's idea of social capital, i.e. networks of people, families, support, friends, resources within the community. That's one aspect of recovery capital. Then you have physical capital, like your house, your finances, your education, cultural capital. I think there's a fourth one where it escapes me, but really what it's saying is people who are well resourced already can go about doing that and really needing either really, really limited or no support at all. And it makes sense because if you're, if you were, used to intergenerational poverty and marginalization and exclusion, and why would you, I suppose, in some ways want to give up taking drugs when it's numbing that sense of hopelessness and powerlessness and not having a stake in society? So it absolutely makes sense. So one of the things, well, counselling and all the rest of the interventions that I spoke about are really important for people who are coming from that really problematic relationship with drugs and substances. Really, really important to help build their social and their recovery capital. So linking them in because they may only have known people who they committed crime with or took drugs with. So it's about developing new social networks, new supports. Finding employment or maybe going to college, if having a partner, getting a job, finding interests and hobbies, because we have to understand that when you're stuck in addiction to that level, from the time you open your eyes at 8 o'clock in the morning, you're either using drugs or if you haven't got drugs, you're maybe going out to steal to get drugs, buy drugs, take drugs, and then repeat that cycle just continuously all day long until you're lying in bed at night time, and the last thing you think before you nod off to sleep, if you do get to sleep, is where am I going to get drugs in the morning? So it's about providing structure and just really rebuilding the person's whole life from the ground up to actually make that life more rewarding than using drugs.
Oh my God, yeah. And how would you know now? I've heard somebody say that an addict never actually fully recovers. Would that be true? Is it something that they battle with for the rest of their life? Or is there a point where you can actually tell someone's recovered and, that's it, they're good?
That's a fantastic question. And I guess I suppose, really, that question often is situated in ideologies and it's embedded in the type of recovery a person engages in. So if you were somebody so I suppose just to name some of the treatment approaches, actually probably contextualize that question a little bit more. Okay. So for treatment approaches, you would have really two broad ways of doing it, so to speak, and often they are integrated together. So on one school of thought would be the likes of, which we've all heard of, AA, NA, so Alcohol Anonymous and Narcotics Anonymous. Yep. And that would the question you posed there would very, very much be situated within that way of treating an addiction. So what those guys would say was that you have a disease. It's a lifelong disease. You're always going to be a drug addict or an alcoholic. However, we have a way of arresting that, if you will, by following these 12 steps, which are spiritual. I suppose they do have a religious undertone in some way, so they won't suit everyone. But really what those guys are saying is, look, admit you're powerless over your drugs or your alcohol, that your life has become so out of kilt that it just got uncontrollable. You can't manage that and hand your life over to some type of higher power. Which is named God, but it can be people's own conception of what a God or a higher power would be. Yeah. So for those guys, they would say, yeah, look, if you stop doing what you're doing and stop coming to meetings or stop living your life in that way, you always have this addiction inside of you. And look, that works for so many people, and equally it doesn't work for a lot of people. I wouldn't be I'm not the biggest fan of it, but look, that's regardless, that's personal opinion. And then on the other side, you would have maybe those who would use more behavioral, cognitive behavioral therapies. So some of the stuff that I spoke about already, so it's about building those kind of recovery capitals and moving on with your life, addressing maybe some of the traumas and the factors that impact on you using drugs. You can be abstinent, but it doesn't mean that you're always going to be some type of drug addict. There's the idea about de-addiction is that after a period of time that you wouldn't be considered an addict, quote unquote, any longer. But then there's also people who give up drugs or give up alcohol, but then would successfully go back using them recreationally. Or having meeting mates on the weekend for having a beer or two, and that's it. They can leave it at that. For other people, that may escalate into further use and back in, I suppose, fall off the ladder, so to speak, and enter back into the addiction spectrum. But it's different it can be different for different people, and that's, I suppose, back to the kind of not homogenizing what addiction is. So it needs to be case by case basis. But certainly there's risk factors there if you're going to go back using drugs or alcohol after having such a problematic relationship with them for so many years.
Okay, the next thing I was actually going to ask, but I think it's just going to be the same answer, that it's different for everybody. I was going to say, what are the long and short term effects of an addiction?
Oh, well, yeah.
But yeah, it's different for everybody, isn't it? Like
it's different for everybody, absolutely. But I think there's some people who may be able to or do maintain an addiction at a certain level for extended periods of times, where they will actually hold down a job throughout their drug use, and their relationships mightn't become too bad. I would say that that's probably a smaller amount of people. Then there's the whole, probably 99% of people who actually don't develop problems with it in the first place. And they would have a smaller number, although, relatively smaller, but still too much, that the consequences come thick and fast. But I do feel that they are exacerbated by some of the issues that we've spoken about already. The two probably biggest factors there for me would be, one, trauma, and two, social deprivation. Yeah. So those would be the two big factors for people whose experience then goes on past that of people who could maybe hold down a job and hold their house, and their relationships don't be too impacted by the people who are out committing criminality, people who end up homeless, people who end up in inpatient mental health hospitals. So for me there's other elements at play there as opposed to just the drug.
Yeah. Okay, case by case. So, and then when it comes to your family and friends, is there any kind of advice that you could give somebody if they're dealing with someone who's a friend or a family member who has an addiction, and what they can do? Because I know, like, how do I say it? Like, a family member can't stop you, a friend can't stop you, but is there something that they can do, maybe to make it easier, support you in some kind of way?
I think this is probably a bit of a contentious area as well at times. So I think there's a lot of the community programs that I spoke about, or nearly all programs that we spoke about so far, would have some element of family support there. So they have workers who will work with family members, but often a family member will come in looking at, I'm looking, how do I stop, Johnny or Louise from using drugs, and they kind of soon come to realize that that's not what it's about. The family support work is about that person, and looking at them and how they're managing and coping. It's not they're not going to be given ideas or techniques to use with the family member that's actually using drugs. You would see on the telly, and it'd probably be done not really done usually here, but probably more of an American thing, where you see the intervention. And the person with the substance use issue walks in the door, and there's a group of people sitting around waiting for them, often with a worker there, and it's a real confrontational, uncomfortable situation even watching it. And that does happen. It doesn't really happen here. It's more of an American thing, and I wouldn't be a fan of it myself, though. At the same time, we need to realize that if someone is in that place, it's really hard for them to acknowledge that and admit that, and maybe put their hand out for help. Some approaches call it denial. Again, I wouldn't be a big fan on that, but sometimes there is the person does need to have some feedback given to them, because it's often the person using the substance doesn't actually feel the impact of that. It's those really the people who are close to them and around them that are seeing it, both the risks the person may be taking, but also some of the behaviour, and particularly if there's fights within the house, because taking drugs does affect your temperament and your mood, and some people may be really chaotic and bringing police to the door, or stealing from the house. So obviously, the family needs to have their boundaries there as well. So I think a lot of the time that can be the defining factor that pushes somebody into treatment. So I wouldn't say, I personally, I just think it needs to be managed well. But look, that's each family's choice and person's choice to deal with it the best way they can, and that's all anybody can really do. I think they often in the treatment centres that would run on the basis of the AA and NA approach, often family members would come down there, and they may sit in a group therapy session with the whole treatment centre, and they will confront that individual on some of their past behaviours. I'm not a fan of that. I think it's too confrontational and shaming as well. But look, that's how those guys go about doing it. So it's far from me to tell them not to. But so that's the type of stuff that would be for families, and then family support. And I suppose there would be a limited role, I suppose, of education and looking for science. But look, if you're after living with somebody who's a drug or substance user for a number of years, I think you'll know all the science inside out at that stage.
Yeah, no, definitely. What would you then say is a better way to deal with this then? Because I know you just mentioned the AA and the NA, and you're saying that you don't really agree with how they do it. What would you think would be a better way then for a person? Like, where would a person turn to then?
I think it's not so much it's NA and AA themselves, the program. I think it's often the way it's maybe sometimes delivered by certain people. So maybe it's not a huge criticism of the program itself. And look, that's just personal opinion. What I do think, and really the ultimate deciding factor for effective treatment, and I guess this is some of my own research that I've published on, is incorporating the whole idea of evidence-based practice. So a part of evidence-based practice, so evidence-based practice wouldn't be just about a treatment modality. In fact, it says very little about treatment modalities. One of the key areas of evidence-based practice is actually incorporating people's preferences. So what it is the person wants. So what it is, how they want you to work with them, what type of interventions the person wants you to work with, and how you incorporate their cultural beliefs and ideas into your treatment approach, how you can work with their values. So for me, if someone says, look, I want to go to AA, I'll absolutely go there, because if you believe that that's going to help you, it actually has a better chance of helping you than not. So it's the whole idea of building expectancy or placebo effect. Likewise, if someone says, I don't want to go there, I just can't get my head around the whole higher power idea, I'd be working with them and say, look, maybe a rehabilitative behavioural type approach may be actually more beneficial for you. Ultimately, if you don't believe in the type of treatment or service that you're getting, if you haven't got confidence in it, it's in all likelihood not going to work. And I think what happens then, and it happens in a lot of these places, is that person then is seen as resistant, as being in denial, and it's a failing on the person's behalf and not on actually the treatment approaches behalf. So and then that brings up its own issues in the therapy setting, where it's quite easy for a practitioner to get frustrated and blame the client, and then as a client, you may start internalizing that, and it could impact you ever sticking your hand out for help again. So I'm really about incorporating people's feedback and their preferences and how we can adopt the treatment style and approach as much as we can to meet those needs.
Well, yeah, that's it, because if someone doesn't want to do something, you can't make them, and sure, it's just useless, then they'll just be there but not there, if that makes sense.
Absolutely. They may not even be there. In all likelihood, they're going to walk out if you're being confronted for being in denial or for being difficult, or not open and defensive, when it's not actually, you really fundamentally don't agree. I guess it's like if you went to the hospital and you may be, you don't know, you have, maybe say, let's say you had something like diabetes, and you went to the doctor and he said, look, here's these injections, you need to take these every day, and you're absolutely terrified of needles, but the other option was a tablet or a pill of some sorts, and you weren't being offered that. How would you feel? Exactly. An analogy around it. So it's the whole idea of evidence-based medicine or evidence-based practice within the therapy sense.
Okay, cool. Darren, I won't lie to you, I thought that was So interesting, and I could probably sit here and ask you tons and millions of questions. Sometimes when you were talking through that whole thing, my mind was kind of racing, and I was like, okay, what do I ask next? What do I ask next? But I think we'll wrap it up here for now.
Oh, that's fine. Perfect.
We'll end it with, I suppose, is there anything that you kind of want to add to what we were just talking about?
I guess to sum up, I think, and it's probably quite apparent if you've listened throughout the podcast, is that there's no simple answers. People are different, addictions are different, ways of working are different, and service provision is different, and even policy is often different. I think ultimately to work effectively within this space, in my experience, and I suppose having spent over a decade in that. Is meeting people where they're at, engaging with people at, I suppose, their level. And when I say their level, I mean where they're at, be that with their motivation or drug use, nothing else. Do you need to just support them and be a ear for them to speak to you, a cup of tea, provide needles or paraphernalia, or is there something more the person wants? And if they want more, well, then you work with them to help them, to support them to get that as well. The treatment, the approaches are probably not as important as the person delivering them, and it starts with an empathetic and caring person who's willing to negotiate goals and willing to work with a person within the context of what they want. So yes, that's it.
Perfect. That's great. Thanks very much for coming on.
No problem. You're welcome.
And that was Daryl Mahon, our in-house expert in social science on the topic of addiction. I hope you found this informative and interesting to listen to. That's all for this podcast, you guys. Goodbye for now.